So with diastasis recti, what we want to do is have great lat mobility, good core activation. We want to minimize or eliminate a lot of the side to side or rotational movement because we have this gap that we can't have things jumping back and forth between. It's really hard to transfer energy from one side to the other. We want to minimize the amount of coning that you're seeing throughout the day by either avoidance, and I'll show you that, or activation, and I'll show you both. So to get the lats moving, I honestly love hanging on the monkey bars when I'm playing with my kids, letting my pelvis drop and then just kind of stretching side to side. You can also use a foam roller and lay on your side here, and I can roll the lats out. So from the bottom of my shoulder blade downward, this can be really sore if these guys are tight. And then I'm going to the other side, doing the same thing on this side, getting those lats to move. The lats attach into the pelvis, so we have to have good movement in those to heal a DR. The other thing is, once we start to get to the abdominal wall, sometimes in the clinic, I can actually actively close my patients' DRs by doing visceral or soft tissue manipulation. So a lot of times with DR, the obliques are tight, so that's pulling this apart, and then putting more tension on the rectus, and that's what pulls it apart. So what I can do is I can do some soft tissue work here where I'm going through and like releasing the abdominal wall. And you can do some of this at home yourself. You know, like if you feel trigger points in your abdominal wall, like right there I have one. So then all I need to do is push my hand into the trigger point, twist in one direction, and then try to breathe once I'm there to get the trigger point to release. I can also put lotion on and just start like moving this around. You're not gonna do anything wrong, like with the abdominal wall. It's just like the better it moves, the better it is. So then once I have that done, I want to start activating the deep system. So we want our transverse abdominis, which is our deep muscle, meeting the top of our rectus. There's a difference between like having the gap and having a functional like diastasis recti. So a functional one would be where the transverse abdominis is coming behind and like giving that DR support. A non-functional one would be where you still have the gap and there's nothing coming up to help support. So what we want to do is the pointy sides of our hips, we're drawing those inwards like I'm closing a book. I'm getting my pelvic floor on, so tailbone towards the butt line, everything flattens, and then I can just start to lift my head, bring that back down, and then again activate. I like to activate, do a movement. Activate, do a movement, because that gets the brain to start recognizing these things. So then I can start to do some like marches with the DR. Again, I'm avoiding at all costs rotational movement. So an example of that would be getting up. So if you have a DR, what I would do is push my arm from the opposite side and my leg into the bed, roll to the side, and then I'd be pushing up with this elbow. So that's called a log roll, and then that's gonna help reduce some of that coning that you're seeing. Also, if you're doing planks and things and start seeing coning, then I would completely take all that stuff out because we wanna like help close, not help widen the gap, if that makes sense.